go ahead. Answers and doubts, please ping in the chat box. Okay. So we'll go to our first question. Just read the question carefully. A 20-year-old male patient reports to the clinic with a swelling in the lower front tooth region. See the image, okay? For the past 2 days, okay? He has a habit of using toothpicks to remove food particles lodged between his teeth. What could be the probable diagnosis? Okay? You guys first give me the answer, then we'll discuss each option. Okay? That's how it goes. Basically, when it comes to any image-based question, no, one good thing is it will be very pathognomic of the particular condition or disease or whatever that we are going to talk about. Okay, there will be no doubt or second guessing. The only thing is the answer might be a little tricky. That's one of the two options or three options may sound right for the question. Okay, but the image will be so classic for that particular condition. Okay, so now give me the answer for this question, then we'll discuss which is the correct option. Ping your answers in the chat box. Okay. Okay. So, anyone else wants to try? Most of us are sure. No, it is not D. Okay, I have not got D at all in the answer list. Okay, so we know that it's not papilloma. We'll rule out each thing and get to the correct answer. Okay, it's not papilloma because papilloma is directly caused by HPV. Okay, and it will look like cauliflower-like or warty growth. Okay, it's a viral infection, and for 2 days. That's another clue. So it's not papilloma. Most of the answers that I got is B, that's traumatic fibroma. Okay, first I'll tell it is not B. First I'll tell you why it is not traumatic fibroma, then I'll tell you what is the answer. Okay, traumatic fibroma meaning what? Yeah, as you said, it could have been because we have put in here that the patient is having habit of pricking or removing food particles using toothpicks. Yeah, correct. He could have traumatized the gingiva. That part is correct. But traumatic fibroma meaning what is? Fibroma is the proliferation of the connective tissue. Okay. And it happens due to a chronic irritation on the particular tissue. It could be even gingiva, tongue, or mucosa. Okay. Something that keeps nagging and irritating the particular tissue. What will happen is the fibroblast will get active and the connective tissue proliferation will occur, which will lead to traumatic fibroma. This is a acute condition. Suddenly he has got, after doing this, he has the habit, but suddenly he has got this swelling. So it could not be traumatic fibroma. It's not chronic. Okay, and one more thing is related to the consistency of the condition. Traumatic fibroma will be firm in consistency. This you cannot decipher by seeing the image. We are just assuming that it could be soft and fluctuant. So it could be an abscess only. So we are down to two options now, the periodontal abscess or the gingival abscess. Okay, the correct answer is it is a gingival abscess. Okay, the difference between gingival abscess and periodontal abscess lies in its name only. Okay, gingival abscess meaning it affects only the gingiva. Periodontal abscess meaning it will affect other tissues of the periodontium. Periodontium has four, no? Gingiva, PDL, that is the periodontal ligament, alveolar bone, and cementum. When it affects any other tissue other than gingiva, it is known as the periodontal abscess. And we know the correct definition or the thing for abscess is that it's a pus collection, a collection of pus in a region. Okay, why gingival abscess? First I'll tell you why gingival abscess occurs, then I'll tell you why periodontal abscess occurs. Why gingival abscess occurs is because of some kind of or trauma to the gingival tissue. Okay, I'll have put this up in the next slide. So I'll tell you with the keywords. These abscesses are localized in the gingiva alone, caused due to injury to the gingiva. Okay, this can occur concomitantly with a or without a periodontal pocket. So that is how a gingival abscess develops. Because of a sudden irritation or trauma to that region, the inflammation and infection flares up and you get a collection of pus in that region. Now, How do you differentiate this from periodontal abscess? Okay, this why it is not a periodontal abscess, that's another thing. We have not mentioned any pocket or underlying periodontal condition here. That should itself give you a clue that it is not a periodontal abscess. And the other thing is, he's a 20-year-old male. Not see, there could be a lot of other associated conditions. It's not only chronic periodontitis, but in general, and this his oral cavity, and look at the other teeth, they look somewhat okay only. So we can assume that he could be periodontally healthy. Okay, at least he could be only in the gingivitis stage, not the periodontitis stage. Okay, and now, why does the periodontal abscess then occur? Because we always say, periodontitis is a chronic disease. It builds over time, and all the bone loss, and there is a continuous host defense and bacterial attack that is keeping on happening. You have this periods of destruction, then reformation, again periods of destruction, then healing. No, so in any, there have been lots of patients who could still live and are living comfortably with periodontitis. So, in what cases periodontal abscess will occur is when there is some other trigger. There is a sudden exacerbation of this, there is sudden periods of exacerbation and destruction. No, when there's a sudden period of exacerbation and destruction in a deep pocket, this can occur. That's the first thing. Okay. The second thing is, in very deep, you would have known the classification of pockets, right? Simple pockets, compound pockets, and complex pockets, and spiral pockets, right? So in very deep pockets that's involving more than one tooth surface, there is a possibility that food debris or even calculus or plaque can go and accumulate and clog the entry to the pocket, because it's no more a sulcus. It will clog the entry to the pocket, thereby build up infection there and derive as an abscess. The last point of how periodontal abscess develops is through surgery or non-surgical intervention. Because see, we do scaling and root planing or surgery, right? There could be very minor instances or chances that a small specule of calculus or a small part of plaque is left in the deepest region of the pocket that we are not able to instrument. So suddenly it will flare up and represent as a post-surgical abscess immediately in the after surgery period. Okay, in the post-surgery period, it can develop as a periodontal abscess. And the last thing is, it could be related to underlying immunologic or lessened host defense. We know, no, in multiple abscesses are very common in diabetic patients, right? So something like that, when the host defense is too low at a point of time, this condition will flare up and lead to an abscess. Okay, any doubts on this question? I'll just go through the question again. See, the key points in this question is swelling in the lower front tooth region. He is apparently healthy, okay, and for the past 2 days with history of trauma to the gingiva. So, this is a clear case of gingival abscess. The answer is C. Okay, any doubts in this question? Any doubts in this question? Can we move to the next question? Okay, good. So, identify the technique shown in the picture. Okay, well, I'll tell you first why I put up this question. Okay, even one of the last year's NEET paper, we had a question on the recent advances, recent techniques. Okay, they'll give you either the technique or a part of how it or the material used for the technique, and ask you to identify or give some point about the technique. Okay, so in all subjects, this is not only for perio, I'm just giving it as a suggestion for all subjects, just to keep abreast of all the newer things that have come up in the field. Okay, so that this could also be potentially asked. These are the new things that are coming up, and we are trying to make them the new normal. These things will become standard procedures, are becoming standard procedures. They will become standard procedures in future. Okay, so identify this technique. First tell me, this is used for at least what? Is it a flap or osseous surgery or mucogingival surgery? What technique is this? And then I explain all the techniques. I'll tell you what technique is this, and I'll explain all other techniques that I've put up in the question also. First tell me, what does this relate to? Does it relate to implants or mucogingival surgery or basic flaps, regeneration, resection? Which one? flap. Mm. Basically, yeah, good. It's a mucogingival surgical procedure. No, it's not frenectomy. It's mucogingival surgical procedure. Frenectomy is also part of mucogingival surgery, but then this is not a frenectomy technique. Okay. Any guesses? This was introduced in 2011, so it's not very recent, but then it's a ongoing thing. There are a lot of studies on this right now. Pinhole. It's not a pinhole. The incision looks bigger enough than a pinhole, so it's not a pinhole. Yeah, pinhole is much more recent than this. Okay, I was about to give the name of right now. Okay. Mm. Yeah, I got the right answer. Good. This technique is the Vista technique. Okay, I'll explain to you what is Vista. First, I will finish off with the basic thing. Even now, okay, it's been till I think more than 20-25 years. The gold standard for mucogingival surgery and root coverage as such. Okay, mucogingival surgery is a broad term. Okay, it's a perioplastic surgery. It's a broad term. Root coverage procedures or recession coverage procedures, the gold standard is coronally advanced flap. I think all of us know what is the basic coronally advanced flap. Okay, this is the Vista technique. I'll explain Vista first, then we'll go to the other options. What we do in Vista technique is we make an incision in the frenum only. Okay, this is for access. That's why it's called the access incision. We make an incision in the associated frenum. Here you have the recession defect in the central incisor, right? We make an access incision through the frenum and we use what is called as a tunneling instrument. Okay, this is a minimally invasive procedure. We are not elevating the entire flap. Okay, we are tunneling through the incision. This is a subperiosteal tunnel, meaning periosteum is left intact on the bone and the entire flap is elevated through the access incision, and what has to be done is you have to continue this tunnel. That is why it is called a tunnel on both sides. You have to continue till one adjacent tooth on each side and to the mucogingival junction, then only it will become free, because all mucogingival techniques have a basis on coronal advancement. Okay, the amount of coronal advancement you get is the predictor for the amount of root coverage you will get after the surgical procedure. Okay, this is a known fact. This was given by Cortellani and Tonetti. So you for advancing, no, you will have to remove all attachments. That's why you're going beyond the mucogingival junction apically. Okay, either even in the maxilla or the mandible, above or below. Okay, so you have to go beyond the mucogingival junction and also through the sulcus. You have to elevate the complete flap here. Then for this technique, what we use is a collagen membrane. Okay, collagen membrane which is saturated with RHPDGF. That's a platelet derived growth factor. What they do is they saturate place the collagen membrane in that solution, RHPDGF solution, saturate it, place it covering the dehiscence and the recession, then make vertical mattress sutures only. This is called coronally anchored suture. Okay, what we do is only a vertical mattress suture anchored at the center of the tooth using composite stops. Okay, this is called coronally anchored suturing. That is what is done here. And the primary incision, no, this is the access incision. This is sutured again. So this is the result. Okay, this is the first technique that was depicted in the question. Coronally advanced flap, I think all of us are clear. We give subpapillary incisions, give vertical incisions and completely elevate the full thickness flap. Place a graft. It could be connective tissue graft or even collagen membrane. Even growth factors and PRF is tried. Yeah, Vista is for recession coverage or root coverage. Okay. This was given by Zade in 2011. Zadeh, Zade in 2011. Okay. And as I was telling, we'll keep the graft. Okay, whatever the graft may be, it could be an autogenous connective tissue graft or a collagen membrane or growth factor. Then coronally advance it and suture it all over. Okay. The pinhole technique, in contrast, was given by Choi. Okay, in 2012. What is done is a pinhole is created, as you can see here. A pinhole is created and they have specialized instruments. Okay, Chao in 2012. They have specialized instruments and you have to use only that kit. That is the disadvantage of this technique. Only if you have the kit you can do. With that, you will dissect these fibers and the elevate the entire flap, okay, both sides to the mucogingival junction and coronally, and slowly, just like keyhole surgery, they will bring down the flap as much as possible and coronally advance it. Place small strips of collagen material. We don't see in all these things you place a entire strip or complete rectangular piece of the graft or the membrane. Here they what they do is they'll take small strips and insert it through this, because it's a very small region. Only we are working only through this pinhole. So through the pinhole only a very small strip can go. So they will cut the collagen membrane into very small strips and align it over here and suture it. Okay, that is the pinhole technique. Coming to the MCAT technique. MCAT technique is actually modified coronally advanced tunnel technique. Okay, it was. Is it clear now? We were discussing about. I'm getting a feedback that my voice is unclear. We were discussing about the Vista technique. I have to first give you the full form. Vista is vestibular incision subperiosteal tunnel access technique. Okay, the entire technique you can get it from the name only. The vestibular incision subperiosteal tunnel access technique. Okay. Then we were discussing about the gold standard CAF, that is the coronally advanced tunnel, and now the pinhole technique. Any doubts in this technique? If there's anything, I'll clear them and I'll then go to the last technique for this question. Any doubts in any of the three techniques that we're discussing right now? Okay, then. So the last technique for this question is the MCAT technique. Okay, it was first introduced it was introduced some 20 years ago. The coronally advanced tunnel or the tunneling the precursor of these tunneling techniques was given by Azzi. AZZI. Okay, Azzi was the pioneer who gave this. He said that you need not make vertical incisions and elevate a complete flap to do root coverage. You can just tunnel in, put the graft and suture, coronally advance and suture. So the idea started with Azzi, but what technique I'm showing here is Zur. Is that you? Zur's modification, because he's doing microsurgery using microsurgical blade. You can see microsurgical blade and microsurgical tunneling instruments. We are going into minimally invasive techniques in this time. No, we are not using the macro instruments. So the microsurgical technique was given by Zur in 2007. Okay, what we do is, again, you see the recession in the upper anterior region. Give sulcular incisions, okay, all throughout, and then use the tunneling instrument to elevate a tunnel through the sulcus. Okay, same rule applies. You have to elevate it throughout, like it should go through. You should not split the papilla. The tunnel should go through, but you should not split the papilla. Okay, all over, one tooth extra on each side and beyond the level junction apically. Okay, once that is done, and you can see in this picture, see the papilla is not split, but the flap is a full thickness flap. You can just lift it up. Okay, once that is done, graft is placed into this tunnel, like through the tunnel only you can place the flap in position, held in place and sutured. Okay, this is sutured using lasso sutures. Okay, graft is held in place using lasso sutures. The name is only slightly. MCAT is modified coronally advanced tunnel technique. Okay, the name is only little new. Okay, lasso meaning you will have to. There are anchoring. It's kind of an anchoring suture where you will suture the graft to the flap. Okay, and you can even do one thing. You can coronally advance this entire complex and just like I showed you here, you need not, and you can anchor it using vertical mattress sutures to the tooth. Okay, this is an anchored suture. Or there's one more light modification of this, wherein you place the graft and then before surgery, what you have to do is place composite stops here, so that if you are putting suture, it will not slide through the contact and go down. Then put vertical mattress sutures that are being supported by these composite stops. Okay, that is another modification of the MCAT technique. So can we move on to the next question? These are the three new techniques or three recent techniques which are in full flow, to be frank, because MCAT, I think we are having numerous studies right now. It's more than 10 to 15 years of research. Vista, a lot of studies are coming up right now. Okay, only 4 to 5 years of research we have on Vista. Pinhole is like completely new. Many people are doing it, but then it's completely new, and we are getting a lot of case reports and other things. We are yet to go into systematic review stage for these techniques. Okay, can we move on to the next question? Yeah. Okay. So this is not about any surgery or anything. First, this picture is something that all of us know like by heart. Okay, red complex, blue complex, green complex. Identify the diagnostic technique behind this key study. This is a very nice study and a very extensively done research. That's why we are able to get these. Actually, it's a single picture for us, but you will be really surprised if I tell you that they have processed more than 13,000 samples to get this picture for us. Okay, they have done 13,000 samples for this study. It is Socrates' classic study on microbial complexes. Okay, he derived the key complexes in periodontal disease through the study. What they did was, I'll tell you the study as we go. I'm getting a lot of answers. C as bacterial culturing. Bacterial culturing is gold standard for any study in general to compare with any other new technique. The USP of this concept is that Sokransky himself, yeah, great. I got the answer from Amina. Sokransky himself devised this diagnostic technique prior to the study to use for the study, and they were successful and they put up the results, and that's why we are having these complexes right now for again more than 20 years now, because this was done in 90s. Okay, 1998 to be precise. The answer is A. Checkerboard DNA hybridization was done. Okay, and I'll tell you about the study. What they have done is they have taken plaque samples from 185 subjects around each tooth, one sample from each tooth. They were doing clinical analysis for 6 sites. Like we probe around 6 sites. No, they did full mouth probing for all these 185 subjects and took one sample from each tooth, and then they analyzed for the bacterial complexes that are present in each patient and gave this summary. Okay, so this is the DNA hybridization, checkerboard hybridization. What we do in this is we have multiple DNA probes. It's not just one DNA probe, multiple DNA probes clogged against multiple samples. Put up against multiple samples, multiple DNA probes and multiple samples. Positives will be indicated by the dark lines. Okay, that's how they were able to find out the different species and categorize them into colors. And one more thing about this colors is that they put up these colors now, red, orange and green especially. Other colors were added again to divide them into separate groups based on their virulence and pathogenicity. But the idea for color coding this entire thing came up by the idea of traffic signal. Okay, red meaning severely related or the pathogenic, severely pathogenic P. gingivalis, T. forsythia, and T. denticola. Green meaning okay, somewhat okay species, commonals. Okay. Uh, are you able to hear me now? Like Kaustav is telling me that my audio is getting cut in between. Is it the same for everyone or it's only him? Okay, so I'll repeat whatever I told. We are clear about DNA hybridization. No, DNA checkerboard hybridization is, it looks like a checkerboard. Okay, meaning multiple DNA probes are put up against multiple samples, and positives are indicated in the dark spots. Okay, see here, positives are indicated by dark spots. That is the concept of checkerboard DNA hybridization using DNA probes. That's how we find out which species is present in the sample that we are taking. Okay, this test was done for analyzing the samples from patients, 185 patients, and each tooth was sampled. Okay, 6 sites were taken for clinical analysis, but each tooth was sampled, and we got around, they got, okay, it's not us, Sokransky got around 13,000 odd samples and put up this summary. Okay, these were the complexes. Red being the most pathogenic and most related to periodontal disease and associated with periodontal breakdown. Green being probably a common cell, still associated with periodontitis, but not much of effect. Okay, that is why they put this red, orange, and green similar to a traffic signal. Okay, this is the microbial complexes study by Sokransky in 1998. Okay, this came up in 1998. Can we move on to the next question? Is this clear? Okay, good. Identify the proponent of this flap technique. First, identify the flap and tell me who introduced this flap technique. This is done especially in only aesthetic zones. Yeah, good. It's a papilla preservation flap. Tell me who gave the papilla preservation flap. Almost all of them are related to papilla preservation flap, but this is the classical papilla preservation flap technique. Okay. Yeah, very good. I got the answer. Takei gave the classical papilla preservation flap. Actually, Kromer was the first person behind the concept of doing papilla preservation. But however, the surgical procedure was outlined by Takei, so he takes the credit. Okay. So Kromer in 1956 was the first person to report the idea of doing a papilla preservation flap. Why we do a papilla preservation flap is to preserve the aesthetics, or else you will get papillary recession. Okay. If you split the papilla here and open a normal flap, okay, there's a possibility that aesthetics will be compromised. Papillary recession will be there, and something called the back triangle will occur. So that's why we are doing papilla preservation flap. Then Takei in 1985 gave this I think all of us are clear about this. We give intracircular incisions on the buccal aspect, on the palatal aspect, no, just at the base of the papilla. This curve should come at the base of the papilla. At the base of the papilla on the palatal aspect, hit it through the bone, like to the bone. Okay, give a full thickness incision. Slowly, very slowly elevate this and take it through the interdental space to the other side. It's actually very easy to like tell now when I'm telling. When you're doing, you should be very careful, because even though you have done, you will obviously do phase 1 therapy prior to opening a flap, right? So you are expecting the gingiva to be somewhat firm. It's not very soggy, but then you are expecting to be somewhat firm. It will be okay, but still this thing is a very tricky process, taking it through the interdental area to the buccal surface. No, there is very high chance of splitting the whole triangle and taking it away in a small piece. This triangular thing. Okay, so you should be very careful when you do. You can do it with the elevator, very gently, slowly take it up. Just like this picture is classic representation of the surgery. Just like how it's shown in this picture, the papilla come out through the buccal side, so that we can put it back in suture. Once you finish the uh, cleaning, like if you are going to do SRP for open flap debridement, just SRP, you can even do resective osseous surgery or even regenerate with this. It's not that you cannot regenerate with this. You can. Okay, if you're doing any other bony, do it and then close the flap. Okay. One of you guys, your audios is on. Kindly mute your audios. Okay. So this is the Takei's classical technique. There is two more modifications given. Modifications were given by Cortellani and Tonetti only as simplified papilla preservation and modified papilla preservation. Okay. Simplified is done in narrow interdental regions. Modified is done in wide diastema cases, wherein instead of giving you take it out, it's just the opposite of whatever I have shown here. You take out the papilla on the parietal or the lingual aspect. The incision is given at the base of the papilla here in the modified papilla technique, wherein when you have a diastema or the spacing between teeth is more than 2 mm. When it is less than 2 mm, you make a oblique incision in this aspect and take out the papilla on either side. Okay, that is the simplified papilla technique. And the last was the option was Tromboli. He is not related to papilla preservation as such. He gave another flap technique, that is the single flap approach or the single flap technique, wherein he says for very small interdental defects that are accessible from the buccal aspect, you don't need to elevate the palatal or the lingual flap. What he does is you can just elevate the palatal buccal flap, do curettage or removal of granulation tissue, and even regeneration, resection or regeneration, depending on what is required. Even and regeneration, especially in very, very small intravoni defects associated with the interdental region. And then just close it up. Okay, you don't need to elevate the palatal or the lingual side at all. That is why it is called a single flap approach. Okay, so this question is also clear, means we can move on to the next question. Okay, can we move on to the next question? Any doubts in papilla preservation? Identify the procedure depicted in this picture. It's very easy. I think all of you will tell. Identify the procedure depicted in this picture. Yeah, I think this is direct, right? It is photodynamic therapy. Okay. Only doubt you will, it's not ENAP, obviously. It could be LANAP, okay, laser assisted excisional new attachment procedure, but then it's not LANAP also. Okay, so it's not ENAP, and but LANAP was not given as an option at all. So it's not ENAP, it's not inadvertent curettage. It could be either photodynamic or LLT. Okay, you use a dye only in photodynamic therapy. In LLT, you don't use a dye. So the answer is B, that is photodynamic therapy. Anyone can explain or just give me the concept of PDT in very, very simple terms? Okay, I'll explain. Okay. See, what we do is we first put a dye into the sulcus. Okay. This is for laser assisted microbial killing. Okay. We put a dye into the sulcus. The dye could be tetracycline dyes or or tetrapyrrole dyes or fluorocumarin dyes. Okay. We all know soralin, right? Soralin is a fluorocumarin dye. It could be either other things also. Methylene blue is most commonly used. That's what is shown in the picture. You can even use acridin orange or erythrins or cyanins. Okay, but methylene blue is very commonly used. We place it onto the gingival crevice. Then, like after SRP, okay, this is done after SRP. After a round of scaling and root planing, we place the dye and activate it using laser energy. Okay, what happens is oxygen dependent reactions wherein you get a lot of reactive oxygen species. Okay, because of the and singlet oxygen, okay, which is destructive. What will happen is it will go and attack the microorganisms and sterilize the sulcus. That is the concept of photodynamic therapy. Now, how is it different from LLLT? LLLT is a very low level laser therapy. That's why it's called LLLT, low level laser therapy. That has a totally different principle than PDT. It doesn't aim at killing anything. It aims at regrowing and regeneration. Okay. What it does is most commonly we use diode laser or argon neon and gallium arsenic kind of lasers. Okay. Type 3 lasers, very low dose of the laser is given into the, imagine the sulcus. Okay, I'm not showing any of these pictures. For LLLT, very low dose of the laser is given onto the tooth or the gingival crevice in question. What will happen is it will start, this low dose laser has the ability to start multiple reactions at once. It will start going and triggering the macrophage for a minor inflammatory reaction so that the microbial products are cleared on one end. On the other end, it will stimulate fibroblasts so that connective tissue repair can occur. The other thing is it will start stimulating osteoblasts for bone production. Okay, so and also simultaneously bring out a lot of growth factors so that all this can be coordinated and some amount of repair will occur in that region. Okay, that is the concept of LLLT. Okay, and I think all of you know about the excisional new attachment procedure that's not practiced anymore, and the inadvertent curettage is also, like when we are doing SRP, some amount of the epithelial lining gets curettage. Okay, that was just two dummy options. Okay, the only two important options in this answer is photodynamic therapy and NLLT. You can see the dye directly, so it's photodynamic therapy. If the dye is not there, probably it could be even LLT, because we use almost the same laser but a little lesser dose. You don't see the dose in the picture, right? So you don't know. So can we move on to the next question? This is the, see, it almost looks similar. This is the LLLT, inadvertent curettage, and ENAP. ENAP is not practiced anymore. Like we are not doing it much anymore. LANAP was done. Okay, it's the same thing. Internal bevel incision using laser has been practiced. That is laser assisted ENAP procedure, but still that's also like becoming a little redundant nowadays. We don't do all that. Okay. So moving on to the next question. A 47-year-old male patient reports with a pocket of 10 mm in this tooth, 3/6. Concurrent radiographic image gives bone loss up to junction of middle and apical third. Give me the treatment plan. What could be the answer? Is it SRP, tunneling, or root resection? If it's root resection, which root are you going to resect? Imagine this patient is sitting at the chair, okay, with these findings. The lingual part is not much clear, so but going from the radiographic image of middle to apical third bone loss, it could very well go through, so it could be a class 3 furcation. Okay, so what would you do for this? What could be the answer? Is my audio clear? Is the question clear? Because I have not even got one answer. Are you thinking what to do? Okay, most of you are telling me B, tunneling. Okay, it's not tunneling because for this extensive bone loss, tunneling meaning what you will do, you have to do odontoplasty, so that, and osteoplasty, so that you can make the patient maintain the furcation by himself, right? That is the concept of tunneling, right? But so for such extensive bone loss, till the middle and apical third, do you think he will be able to put in an interdental aid and clean every day? No. So that's why tunneling is ruled out for this patient. Okay. In general, one of the standard procedures for class 3 would be tunneling, but then this particular furcation is a little problematic one. So we are not able to make a tunnel to make the patient maintain by himself. Okay. So that is why it's not a tunnel. The other thing is, since we cannot do tunneling only, so there's no concept of just doing odontoplasty and closing the flap. The answer is root resection only. Which root to resect is the question. Okay. And I got the answer. Okay. Amina, did you guess, or like, can you tell me why it's the mesial root? Amina has told me it's the mesial root. It is the mesial root that you have to resect. But can you tell me why? Okay. I'll only give the explanation. Why the mesial root is because the mesial root has most problems when it comes to the mandibular lower molar. Okay, so it's easy to resect it and get off with it. The distal root is easy to prepare when you're going to go for prosthetic replacement, or if you're going to do, obviously when you're doing root resection, the tooth has to be endodontically treated. Ideally, if you are planning the case before, the endo part should be complete by the time you open the flap. Okay, because or else you will have pain. Most commonly you will have pain. So endo has to be completed before you go in for the flap. Even if you don't do, by chance you open the flap first, see the bone loss that is so severe and you are planning resection at the table, you do go ahead with the resection. Within 1 week the endo has to be completed. Okay, that's why mesial root is resected first. Distal is easier to even endodontically access and finish the endodontic treatment. Okay, that's why mesial root is resected for a mandibular molar. By chance, I have given middle to apical third, meaning the bone loss could be equal in both the roots. That's why we are deciding as mesial. By chance, the bone loss is more in the distal root, you go with the amount of bone loss that is present. The most damaged root will be taken off. Okay. This is based on Basarba's criteria. There are 5 or 6 points related to Basarba's criteria for root resection. One is the amount of bone loss has to be taken into consideration. Then the amount of and that is the amount of prosthetic or endodontic treatment that can be done in relation to the particular root, because it's not the tooth anymore, it's the root. Okay. Then whether that particular tooth or the root can be taken as an abutment, and the prognosis, whole prognosis is calculated, and then which route to resect is planned. Okay. So we'll move on to the next question. This is easy. A periodontist is practicing four-handed dentistry and asks his assistant to hand over this instrument on the table. Identify this instrument. I won't answer fast, guys. It's so that we can move fast with the rest of the questions. Yeah, good. It's a periotriver. Okay, I got the answer. It's a periotriver, Schwartz periotriver. Okay, for it has a magnetized end to remove small broken tips of instruments from the pocket or the furcation area from the periodontal tissues. Okay, Quinton's furcation curettes look like this for instrumentation of the furcation region. Okay, the furcation, our curette no has a diameter of 0.7 at least, and furcations are much lesser than 0.7. That's why our normal curettes don't work, and we use specialized furcation curettes for furcation therapy. Bone files are of two types, Schluger and Sugarman. Sugarman is the straight one, Schluger is the curved one. Okay. The next question. This is very easy. Identify the parameter assessed in this picture. Identify the parameter assessed in the picture. Guys, I want the answers to be a little fast. Yeah, and this is very easy, right? Yeah, good, very good. Width of attached gingiva. Okay, I just want you to answer one more thing. Does width of attached gingiva increase or decrease with age? Just give me I or D. Good, super. Okay. This is the manual method for measuring the width of attached gingiva. The Schiller's potassium iodide solution and our classic roll test that is performed at the at the junction of the, you will be able to see the movable mucogingival junction. Like this is the mucogingival junction, movable mucosa beyond that, and the attached gingiva in front of that. Okay. We can even do a tension test wherein you just hold the patient's lip and give some tension. So the free gingiva and the mucosa will move, attached gingiva will stay. That's a very gross, very gross method of estimation of the width of attached gingiva. So we'll move right away to the next question. Identify the purpose of this step in osteosurgery. First, find out if it's osteoplasty or osteectomy. If it's 1, 2, 3, 4, first step, second step, I'm not giving the names of the steps of ROS. I think you will know. So identify whether it's the first, second, third, or fourth step, and tell me. If you identify that, you will be able to know for what we are doing this step. First step, good. It is vertical grooving. Okay, it is vertical grooving, but it is not done to blend the bone. Okay, it is done for something else. I'll give out the answer. The answer is C. Okay, it is done to reduce the thickness of the alveolar housing. I think all of us know vertical grooving, radicular blending, removal of the interproximal bone, gradualization of the marginal bone, flattening. Okay, I should not say removal, flattening of the interproximal bone and gradualization of the marginal bone. Okay, that is the steps in ROS. This step is the vertical grooving. That is the first step. It's an osteoplasty step, meaning reshaping. I am not removing tooth supporting bone. Only if I am removing tooth supporting bone, it is called osteectomy. It's an osteoplasty step. Just see the picture, then you will know. See, it is done to reduce the thickness. It is done most commonly in case of bulbous bony contours or ledges or thickened bony plates. For that only we are doing vertical grooving and radicular blending. We are giving vertical grooves, no? So we are measuring or delineating the dimensions of the buccolingual width of bone. So we are trying to reduce the alveolar thickness here. So the correct answer is to reduce the alveolar thickness housing. Okay. This is there, this particular phrase, no, reduce the thickness of alveolar housing. This is there in Carranza only. Okay, this is the actual purpose of vertical grooving. This blending bone surface smoothly, that is for the second step, that is the radicular blending. Okay, that's why blending bone surface smoothly. Can we move on to the next question? Okay, this is how it is done. I already explained. Okay, this is how it is done. It is done with round burr. We do at line angles of each tooth in question. Okay, so that, see, in this also you can actually see we are delineating the amount of buccolingual thickness of bone that is to be present in that region. That is why we are marking the grooves here. Once we finish the second step, we will be complete with the osteoplasty part of resective osseous surgery. Okay, to reduce the thickness of the bony housing. Next, a 52-year-old patient is slated to undergo prosthetic replacement in the lower back tooth region. Which of the following measurements is least critical to preserve the supracrystal attached tissues? Now first, what is supracrystal attached tissues? It is another name for one of the most common things that we speak about when it comes to, I'll give you one more clue, when it comes to crown lengthening and restorations and prosthesis as such. The prostho and restorative periodontal interrelationship runs on this basis. Okay, it is the new name for, no, it is it's not attached gingiva. Anyone else wants to try, or else I'll give the answer. Not ridge. It's not ridge. I'll give you one more clue. It has a definite measurement and is made up of a definite amount of epithelium and connective tissue. Yeah, good. I got the answer. It's biologic width. Okay. In the new classification, 2019 actually we are in 2020 now, going to be 2021. 2019 classification has given this suggestion wherein they are replacing the term biologic width with supracrystal attached tissues. Okay, we are supposed to call biologic width as supracrystal attached tissues from now on. Okay, so give me the answer for this. This, this measurement, why I put up this question is because it is a deciding factor for the kind of crown lengthening procedure that I'm going to do. Okay, so which of these measurements is least? I have given you the procedure also. See, for this patient, I have to do crown lengthening for prosthetic replacement, or else I will not be able to preserve biologic width in this region for him, in the 3637 region for him. So, which of these measurements is not very important? Good. Most of you are right. The answer is D. Crown width is not important. Okay. Prior to doing crown lengthening, first I'll tell you what measurements we'll take, and I'll tell you what are the basic crown lengthening techniques that we do. Okay. We will measure PPD, CAL, obviously. Okay. PPD and CAL, width of keratinized tissue, width of attached gingiva, and also do bone sounding, meaning give anesthesia and probe till the to the bone. Okay, like hit the probe to the bone to know the level of the bone level. Okay, that will decide the amount of resection. Because it is osteectomy only, there is no osteoplasty here. You will have to reduce some amount of bone to preserve the tissue that is there. Okay, So based on that, three things can be done for crown lengthening surgeries. One is gingivectomy. The other is flap with osteectomy. The last is again flap only, but an apically positioned flap. Okay, for straight cut, clear cut cases wherein you have a mildly excessive gingiva or what to say, a suprabony, I wouldn't say a pocket, oh, a suprabony pocket, uh, because it's not a pocket, it's a healthy tissue. The thing is, you have to do bone sounding to know the level of the bone, then you know the level of the pocket. Okay, for example, bone is 5 mm and pocket is 3 mm, you have 2 mm left. Okay, so you can just you may have to increase the length of the crown by a maximum of only 1 to 2 mm. You cannot increase beyond that. Okay, for crown lengthening you cannot cut beyond that, and posterior regions you cannot go and invade the furcation, so it's not possible. Then that tooth will have poor prognosis, you won't even do crown lengthening for such cases. So if that measurement is sufficient, we take biologic width as an average to be 3. So if we are able to get the difference to be anywhere between 2 and 3, we just do a gingivectomy using, this is shown using electrocautery. The picture what I have shown is using electrocautery, but you can do with scalpel, electrocautery, or even laser. Okay, that is at least 1 mm from bone margin. You will have to then, if it is not there, you will have to open the flap. What you do is conventional flap, full thickness mucoperiosteal flap, measure the level directly by seeing the level of the bone, then do 1 to 2 mm of osseous resection and then close the flap. The same flap, this is we are closing it at the level of the bone, right? The same flap, if you have a very less amount of width of attached gingiva, you do vertical releasing incisions and apically position it to simultaneously increase the width of attached gingiva. Okay, this is clear. Can we move on to the next question? Apically positioned flap, APF. Yeah, see why APF is done is, see, you can only do two things for crown lengthening. Okay, you can just cut off the excess gingiva, do a gingivectomy, that is cutting off excess gingiva, meaning you can do a gingivectomy. Okay, if you have a sufficient space for the epithelial attachment to occur again from the bone, okay, that time you can just do gingivectomy, or else you have to do a apically positioned flap or a normal flap with osteectomy. Anyways, osteectomy has to be done. 1 to 2 mm of bone has to be reduced, okay, to give that additional crown height without taking a toll on the biologic width. If you like invade the biologic width, again the restoration will be a failure. So in cases of decreased width of attached gingiva, APF is done simultaneously. The flap itself will, instead of becoming a clavicular flap, will become a APF. You will do vertical releasing incisions and position it apically. That's all. That's the difference. Okay. So the next question. This is also very easy. A 35-year-old patient reports with the clinical picture. Identify the etiopathogenesis. What could this be? We have just two more questions, so we'll just make it fast. We are past 6. Okay. Yeah, good. So this is pathologic tooth migration, and the concept is TFO. Okay. Acute or chronic? Acute meaning sudden onset, abrupt changes. Most commonly, acute TFO will occur due to restorations, high points, fillings, prosthesis that's interfering, or orthodontics, that's wires or components that's interfering, something like that. Okay. Chronic will be gradual change, okay, due to bruxism, drifting, or tooth wear, or periodontal disease, based on the periodontal support. Okay, primary or secondary. Primary meaning healthy periodontium, excessive occlusal force. Secondary meaning periodontium itself is damaged, so normal occlusion itself is becoming a problem. That is the summary of etiopath of TFO. Okay, so the next question, this is also direct. Okay, a 40-year-old female patient works at the petrochemical unit. Okay, she reports with this picture. Identify the agent. This is also somewhat like very direct. Identify the agent causing the staining. Okay, 1 second. The previous answer is weakened periodontal support or increased forces onto the teeth. Okay, see, the picture is classic of pathologic tooth migration. Pathologic tooth migration occurs only because of underlying TFO. Okay, it cannot occur because of loss of antagonist or plaque induced. It's not a plaque induced lesion. Plaque will occur concurrently. Periodontal disease can run in the patient concurrently, but the primary thing is not the periodontal disease, it's the trauma from occlusion. Okay, because of TFO, it is the last stage. No, we have 3 stages in TFO: injury, repair, and adaptation. In the adaptation phase, what will happen is all amount of trying to save the tooth from forces is not happening. So tooth slowly drifts away from occlusion itself. It tries to move away from the inducing factor that's causing this trauma. Okay, so that is the TFO. Okay, clear? Okay, so this is the next question. What is this? This is classically called something. With that, you can identify the answer. Good. This is the classic Bartonian line. Yeah, super. Okay, this is the classic Bartonian line. All heavy metals will cause bluish or violet staining of the gingival and gingiva and the alveolar mucosa. But however, this picture was classic of the Bartonian line that's seen in the marginal gingiva due to deposition of lead sulfide. Okay. So the next question. Treatment protocol for periimplantitis, because it's obvious. Periimplantitis is based on whose recommendations? Answer for the previous question. 1 second. Bartonian line. So the answer is B, lead. Okay. Bartonian line. Okay. So that's lead only. Okay. Yeah, I got the answer for this also. So I'm like we are already over time. So super. The answer is C here. It is the cyst protocol, which is given by Lang. Okay. For what? For staining, Kaustav? Heavy metal staining. Nothing much I have written on this at all. All these, even mercury, lead, and silver will stain your gingiva and oral mucosa. Okay, any of the, and even arsenic. All this will. But this Bartonian line is because of the deposition of lead sulfide. Okay, that is the key component. That's why it's becoming blue or black. Okay, so we'll move on to cyst protocol. It was given by Lind and Lang. Okay, that is the cumulative interceptive supportive therapy. They followed it up with another protocol known as the ACUT protocol, AKUT, ACUT. That's a modification of the same thing. Okay, what you do is you measure the probing depth around the implant. If it's less than 3 and plaque index is less than 1, you just do debridement. If plaque index and deepening or probing is present but still the PPD is less than 3, you do just A, that is SRP. Okay, if it's 4 to 5, you do SRP plus B, that is antiseptic with plus mouthwash. Okay, if it's more than 5, take an X-ray depending on whether the cratering is there or not. If cratering is not there, just do SRP and mouthwash, or else based on whether the defect is an intrabony defect or what kind of defect is there, you will either do resective or regenerative therapy with additional LDDs if needed. LDD and systemic antibiotic therapy if needed. This is the question. Treatment protocol for a patient presenting with this picture. This picture shows periimplantitis. It is based on the cyst protocol. Okay. The other options, I'll tell you why it's not right. Quirinen protocol is a full mouth disinfection protocol. This is a little old concept, not much of use now, but we still do for exceptional cases wherein we generally for SRP, we give at least 2 appointments for the patient. Okay, so this is a concept wherein Quirinen suggests that we complete the entire SRP within 2 days. Okay, 2 quadrants each day with simultaneous subgingival irrigation of chlorhexidine and subsequently prescribing the patient to take mouth rinse, chlorhexidine mouth rinse for the next 3 weeks. So the treatment will be done over 1 month, and the patient is reviewed after 1 month for basic SRP. That is the Quirin's protocol. Aziz technique is again coronary advanced technique for recession, and Nordland's technique is a papilla preservation technique for black triangle. It's a papilla surgery technique, okay, reconstruction technique. So moving on to the next question. Identify the technique for sinus lift given here. Some people are saying it is piezo, some people are telling it's lateral window or balloon. So nobody thinks it's osteotome, no? Okay, it's not the osteotome technique. Okay, somebody thinks it's osteotome. I've got all answers for this question. The clue in this picture is this part, okay? Any more guesses? It's not the lateral window technique. This, see the tooth here. It's a crestal approach only. It's not a lateral window approach. We are going through the bone only here. Ridge. The correct answer is balloon sinus lift technique, okay? Wherein we do a crestal approach, okay? And then this balloon device is there, no? Put it inside and then inflate it when it's within the, just touching the Schneiderian membrane, sinus membrane, when it's just touching the sinus membrane, inflate it so that due to the pressure given by this, okay, we usually use saline also along with this. The whole sinus membrane will elevate, then you can graft it and then implant it later, like do the implant surgery later. This is the balloon elevation technique. The osteotome technique is green stick fracture, okay? Crestal approach, osteotome cuts go in, green stick fracture of this bone that's present here, okay? Just lift it up along and lift the bone up. Along with that, just push the slowly, okay? It's done with a osteotome. Just slowly lift the sinus membrane also up and place the implant directly. That is the osteotome technique. Lateral window technique is for very large kind of defects, sinus defects, and based on the amount of bone left, okay, where the crestal approach is no longer advisable. You do a lateral window on the bone, get the access there, elevate the sinus and graft it. Later, put the implant. Piezo is not any separate technique for sinus lift. This lateral window technique can, or any other instrumentation that we are doing on the bone for sinus lift can be, even the crestal approach for giving the osteotomy cuts for crestal approach. You can use the piezo instruments instead of the normal burrs for surgery. That's the piezo technique, okay? The next question. This is the last question. Identify the molecule associated with this picture. What is this relating to? Okay, those who told me B and C, tell me why is it PDGF in the first place? Good, like most of you have answered it correctly. It's auto-inducer too. What is the concept here? Any one of you give me the concept here. What are we talking about? Guys, what is auto-inducer? What are we talking about when we are saying auto-inducer 2? The answer is A. Okay, auto-inducer, what is it? Okay, you guessed that it is A. Okay, good. It's quorum sensing. Okay, quorum sensing molecule is auto-inducer. Okay, the concept in quorum sensing is, what happens is when the bacteria accumulate, the concept is when the bacteria accumulate in one particular numbers, like they have to be there in large numbers. United we stand, divided we fall, no? Something like that. When they are in large numbers, they start producing molecules like autoinducer 2, which is known as the quorum sensing molecule. These molecules will trigger multiple processes within the particular environment that they are living in. Within the biofilm, they will trigger multiple processes. It's not just one. They are not going to just do one action. They will do multiple actions. The end point is they want this particular species to survive in that environment. To do that, they will start producing a lot of allied molecules and allied reactions. Okay, but this particular thing can happen only if the microbes are in sufficient quantity, and only if they are in sufficient quantity, they will start producing this molecule and amplifying their own response. That is the concept of quorum sensing. Okay, the key quorum sensing molecule is the auto-inducer 2. Now, what this quorum sensing can do, for example, is it can increase the virulence factors in that region for that microbe. Okay, we're just talking about one species here. So, it can increase the virulence factor production or motility or increase the reproduction of rate of the particular organism, so that the end point is to make it the organism stay in the and fight the difference that is happening from the host. Okay, stay within the biofilm and within the periodontal environment. It wants to survive. So for survival, it will do these things for the organism. It will try to increase the virulence or increase its pathogenicity or increase its mobility or reproduction rate. Any of these can be done for the organism. And for the defense, no, it will start counteracting the defense mechanisms that is happening. It can induce antibiotic resistance, or two things: it can start inducing the growth of related species which will also are co-pathogenic in the same environment, or start fighting and decreasing the amount of bacteria that are antagonistic to the particular bacteria that we are talking about. So any of these functions can be done through this particular phenomenon of quorum sensing by this molecule, that is the autoinducer 2. This is mediated through the lux gene, lux gene. Okay, and competence stimulating peptide is again one of these quorum sensing molecules only, but it is produced by gram positive bacteria. It's produced by streptococci. Okay, not much of, it's again the same concept only, but it doesn't have much of influence when it comes to pathogenicity as much as AI2. That's why AI2 is known as the key molecule. That is the molecule that's involved for the periodontal pathogens. Okay, so any doubts till now? With this, we are done with this questions for this session. Any doubts regarding any question? I'll take them right now. Sure, we'll do. Okay, sure, we have done we have done two subjects right now, oral med, and now today I'm doing perio. We'll do more of image based questions in future. This was put up as a live class only so that we'll have an interactive participation in the app. You can get a separate section on image based questions. Go to the lesson page, no, lesson link in the app. You have a separate section on image based questions on all subjects, like it's sorted according to subject. Whatever subject you want, you can go and take up the image based questions there. Okay, these sessions also we are planning to continue, so we'll continue for sure. Okay, as of now we have not planned any class from 1 to 3. Okay, Kaustav, we have not planned any class from 1 to 3. We have another class on mock test on 4th or 5th. Okay, 4th or 5th. I'll just confirm the date. I'm only taking the class. We'll just see about the other image-based questions and let you know. Okay, classes and let you know. We have not. We'll put up the dates and time in the Telegram channel. Okay. Thank you so much, guys. For these image-based questions, now please look at the image very carefully. That's what the key thing about image-based questions is. The image itself is pathognomic of a particular condition. You don't need to search anywhere. Okay, and don't think that okay, just that they have put up an image or clinical scenario, meaning the question is tough. It's not tough. You just have to know the key words or key points from what they are trying to say. With that, you will be able to narrow down to the answer. And thank you so much for patient listening.